My name is Tobias Hagedorn, full-time employed director of the German PKU Association, as well as voluntary general secretary of the ESPKU. Phenylketonuria, in a nutshell, it's a rare metabolic disease where the body cannot break down one part of the protein, the amino acid phenylalanine. That accumulates in the blood, swamps over in the brain and creates damage in the brain. So effectively untreated PKU in principle shows mental retardation symptoms. Children with this disease would not develop properly, would stay on a level of something like 6 months, a year, maybe 3 years. Fortunately, this fate can be avoided. We do have the heel prick test. This newborn screening is probably the most successful preventive story in the world in pediatric medicines, and has saved probably thousands and thousands of lives, not only of PKU children, but also with other diseases that have been included in this concept ever since. So we can diagnose the babies early before they become symptomatic, and then we can treat them effectively with a diet, because if protein is doing the harm to the brain, then we just leave out the protein from the food, from the nutrition. Sounds simple, is very complex, because you would end up in a severe malnutrition if you don't have any protein. So we need to replace all the other amino acids that are not phenylalanine, but the body needs them to have a complete protein and to build up muscles, cells, and brain, and so on, with an amino acid supplement, with a protein supplement. One of our main pillars of our patients' advocacy work is political advocacy. Patient organizations nowadays are much more than what we in Germany called Stuhlkreis, seat circles, where patients just come together, cry out their tears, explain their stories to each other, say, "Hi, I'm Tobias, I'm PKU." That's no longer true. That is basic patient advocacy work, that's basic patient support work, and that's still a huge part of our associations, but in a more modern and fancy way, this exchange of information. But other than that, we also want to improve the healthcare environment. We want to help the patients to have a better healthcare system that is more targeted and more suitable to their needs, and in particular to their unmet needs. An unmet need is a key word for what we are talking here today, the European pharma legislation. Something like 3-4 years ago, the EU Commission came up with the idea, effectively after the pandemic, when they learned the weak points in our healthcare systems in Europe from the pandemic. They said, okay, we need to kind of modernize our healthcare legislation, and we need to review our legislations, including pharma legislation. So they came up with the idea to, first of all, bring all together all the small pieces of pharma legislation into one. So the new pharma legislation will also include the orphan drug legislation that has been valid since something like 2002, I think, in Europe. And we have benefited from the orphan drug regulation very much as patients with rare diseases, because this piece of legislation organized incentives for pharma industries to invest money in research and development in an area that is not a super attractive business case. I mean, we are talking about rare diseases here, and that means that the target group is small. So you are not speaking about huge communities like diabetes or cardiac patients. You speak about minorities. PKU is one of the most common rare diseases with an incidence of approximately 1 in 10,000. There are much more diseases that are way more rare than PKU. So it's not super attractive to invest money in this area. And this orphan drug regulation gave incentives like extended market exclusivity, more easy procedures in the assessments of approvals of clinical studies, and so on. And that was pretty successful, because in the last 20 years, since this orphan drug regulation exists in Germany, in Europe, and I think it was pretty much the same time, even something like 2 years earlier, when the US had something similar. Since then, many orphan drugs have been developed for many diseases. However, there are something like 6,000 to 8,000, maybe 10,000 rare diseases. And all the drugs that have been developed just covers something like 5% of diseases. And for the remaining 95% of rare diseases, there's still no treatment available. That is something that the European Commission understood and said, we need to do something. This must be more targeted. This must become better. We need treatments for more patients. That is the objective. We want to include more diseases. So we need to kind of shift our incentives and focus on investments for rare diseases with a high unmet medical need. That sounds great from the perspective of 95% of diseases. The question here is, should we make policy for diseases or should we make policies for patients, for individuals, for human beings? Because when we look at the numbers, 5% of rare diseases that do have treatments available sounds very small. But when these 5% make up something like 70 to 80% of all the patients, then this is huge. This is a great success. And when now we would shift our incentives away from these diseases to the other 95% of diseases, which just represent 20 or 25% of patients, then we would potentially take away the opportunity to have access to innovation and to research and to scientific progress from those who do have a treatment, but this treatment may still not be sufficient. So our call here is basically to not shift focus, to not have an either-or policy, but to have an as well as policy. It should be done both. So that's number one. And number two is, why are we concerned that patients with some rare diseases might be excluded from scientific progress? And this is where the PKU story could be a perfect example as a role model, what could happen. As I just said, PKU sometimes is falsely interpreted as a solved problem of pediatric healthcare. We do have an early diagnosis, pre-symptomatic, which works super accurate. We do have a nutritional therapy that can fully prevent us from the severe symptoms, mental retardation. My wife is perfectly healthy. We have 2 healthy grown-ups. She lives her life to the full. She has her job, she has her profession, everything seems to be fine. So is there still an unmet need in PKU to invest in research and development for better treatments that might help these patients to, for example, not have the mental health issue that are associated with this strict diet? What are the unmet needs in PKU? And there are a lot. Starting with the diagnostic moment. You can imagine when you come home as a loving mom to your loving family and everybody celebrates the newborn in the family. And suddenly in the midst of this party, the telephone rings and somebody tells you, well, there's some blood level that is not good and that needs to be checked. And we found out in the newborn screening process, your kid could have a disease called PKU, but as a doctor, I do effectively have no clue what this is because it's too rare. I have no knowledge about that. But you should go to the university hospital. They are waiting for you. It needs to be checked. Please go there now. There is an urgency involved. There is a bad news involved. There is a news involved that is potentially life-threatening. Is it? I don't know. As a patient, nobody can give me an answer. So you can imagine this is a likely traumatizing, impactful moment, and that may really impact the family as a whole, not just for that moment, but also for a longer time when they are not able to cope with this and the anxieties pop in and be transferred to the child that grows up with their PKU. And then experience something like when mom is afraid of feeding me because food suddenly becomes a threat. And when mom is afraid of feeding me, how should I, as a patient growing up, develop a normal behavior, a normal attitude towards food, eating behaviors? Then it goes to preschool and school when moms and dads have to learn to give up responsibility and control to other people, to the teachers, and to count on the support that everything will go right at school and they will take care that the lunch break and the breakfast is appropriate according to the nutritional needs of my child? And what happens if not? And how can we execute this? How can we handle that? Then it goes to puberty. I mean, puberty, we all know that. Puberty is the time when parents become annoying. Teenagers just want to be normal, do not want to be seen as something special, something extraordinary. Sometimes PKU patients feel like aliens. So they get loose of their diet, get loose of their dietary control. They are no longer compliant enough to maintain this very, very strict dietary routines in a daily life. And this continues throughout lifehood. I mean, when you are a young student going to high school or university, you make up your new peer group and you want to go out to dinner. I mean, students, I remember it very well. It was a great time. The nights were our days. So we went out for dinner nearly every night. And just imagine it's always you in the focus because your peer group wants to do the very best for you and ask you, where can we go for you? What is suitable for you? You don't want that. You do not want to be the center of the world for the rest of your life. You want to just be normal and to share your social life with others on the very same level. So PKU patients often start to kind of no longer engage with their peer groups and kind of take a step back in their socializing and isolate themselves or become isolated because others do not understand their particular needs. So whatever you look from it, whatever is the reason for it, the result is more social isolation. And that it continues via professional life. I mean, you can't just go to a business dinner. You need to prep yourself. You need to calculate how much fee is in that dish. And when you understand, okay, it's much too much, it's more than I am allowed to have, then the kind of guilt feeling kicks in. Okay, I again cannot cope with it. I again am not compliant with the therapy. And that creates mental health issues. And then they lose more control of their diet and fee levels still increase higher and higher. Sometimes then it's the question on how to return back to the diet and the anxieties about healthy future. What will happen when we grow older? And when other diseases kick in, like diabetes or whatever, because just having PKU doesn't protect you from developing any other diseases. And what does that mean? I mean, just consider you have to have a diet for PKU and to have another diet for diabetes, and to combine those restrictions will be super, super restrictive. When you read about PKU in scientific literature, you read something like PKUs are allowed to have something like 15, maybe 20, maybe 10% of the natural protein intake. Well, that is a small amount, that's clear, but you cannot visualize, you cannot grab it. But when you understand that half a glass of milk contains as much protein as my wife, for example, can have for the whole day, that means it is super restrictive. From that hotel breakfast with the crispy slice of bread, sausage, the eggs, and all these beautiful things, the butter between the slice of bread and the cheese, that is what is allowed for my wife. So the food choice is super restricted. You cannot just go to the supermarket and buy something. That is one of the most famous hand moves in PKU communities. When you see people in a shop taking out something from the shelves and turning it around to see how much protein is in it. When we go out for dinner, beautiful, let's say 2-star chef serves a beautiful dish. You and me, we look to the very same dish and we say, wow, that looks great. And taste is already kind of evolving and we are looking forward to this taste experience. It will be great. Everything, we have positive words for it. It will be a joy, it will be a taste, it will be a great experience. Christine looks to the very same plate and starts calculating. This is 60 milligram of phe, this is 20, this is 24, makes up a total of something like 100 milligram. I can't afford to have it. And the feeling of guilt kicks in. So for her, the very same dish which is associated with positive words for us is associated with negative words like guilt, too much, not compliant, health threat to PKU patients. So there are a lot of unmet needs, and will they be seen when we assess whether a new idea for a new drug should be incentivized within this new piece of legislation in the EU, when the focus and the shift of incentives should go to high unmet medical needs and to unmet medical needs. And to have that staggered approach sounds logical. But on the other side, it may easily be that, okay, if high unmet needs gives you, let's say, 12 years of market exclusivity, an unmet need gives you 10, and no unmet need is just a regular drug, so it gives you something like 7 years of market exclusivity, then the fight starts on who suffers most. And that is also not a good concept. So the problem in this concept is how to, with the best evidence and with a full picture of the diseases, can we assess the true unmet need without competing amongst patient communities. All this is not seen, is not recognized in a political concept of unmet need, which is just focusing on mortality and morbidity. Mortality doesn't change when we have a new drug available for PKU. We do not die later or earlier. And morbidity effectively does also not change if we just look at PKU like Phe levels and brain health. So we need to expand the criteria how we would assess morbidity. What about our quality of life? Is that included? Not yet. It should be included. What about mental health, anxieties, and stress disorders, and all these things that I just highlighted? Are they included when we look at morbidity? Well, maybe, maybe not. It depends on how it will be effectively assessed and who will assess it. Will patients be involved in the assessments? And what are the criteria? So there is much to ask and much to be answered with regard to the concept of unmet medical need as a key criterion for future incentives of the development of innovative therapies. And having said that this is just the example for PKU, then you can imagine how complex it becomes when you not just look at one disease, but at 6,000. And that's the reason why we created this joint policy paper, because we wanted to use our disease, PKU, as an example to explain the complexity of this concept of unmet medical need in research and development and incentivizing research and development. The idea of the European Commission is great and we fully subscribe it. We should do something more to help those who do not have any treatment at all. They need it. They need the support. But we cannot do that for the price of no longer granting access to innovation and to research for patients with diseases who do have treatments, but where we learn that these treatments are not good enough, do not really resolve the problem, because it is not a cure. We just prevent symptoms. It's not we take the pill and it's done, it's away. PKU remains. We only treat the symptoms with the dietary therapy, and with all the existing treatments that we do have, we only treat symptoms, not the disease. I explained why we created this, to explain PKU as one example of why this concept of unmet need in this assessment and direction of incentives is so complex that it is, from our perspective, fate to fail. But the way how we created it, how we set up this joint policy paper is also something that is remarkable, because it's not just patients coming together and write up their unmet needs and go there and shout out for their rights. We created a truly international and interprofessional team of something like, I'm not pretty sure, 27, 26, 28 people who came together to discuss unmet needs in PKU and the concept, the political concept in this orphan drug legislation, in this pharma legislation. That included dietitians and metabolic professionals, as well as patients, patient representatives, caregivers. So there was a whole bunch of different perspectives included. But what was not included is the perspective of industry and the perspective of payers. And that has happened on purpose, because we did not want to have that bias. We wanted to make crystal clear this is not something where we sing from the hymn sheet of anybody who has an economic interest in this question. And I think that is something that makes this paper, I hope, particularly strong. And we do hope that it has an impact and it may change the way the future legislation in Europe will look like, because I do believe that what we do in Europe has an impact on US legislation and US pharma policies and pharma decisions, because pharma doesn't create a drug just for Europe or just for the US. They look at the global perspective. As well as this would be the other way around. So I do believe this is a truly critical moment that will define the next at least 10, maybe 20 years in orphan drug development and research and development. And by that, it would potentially impact and set the way and set the path for patients' access to innovation and to research and to scientific progress.